Today's episode is called Save the Fascia. It's a mnemonic. So Save the Fascia stands for S is for stop the contamination, A is for aggressive irrigation, B is for verified tetanus, E is for evaluate the wound carefully, T is for track the progression, H is for hunt systemic toxicity, E is for escalate immediately, F for the fascia part. F is for fast progression. A is for anesthesia of skin. S is for severe swelling. C is for crepitus and cellulitis. And I is for intense pain. A is for altered skin color. So this is not just a mnemonic. This is not just a tool, a teaching tool, but this is a structured way of thinking that helps force us to recognize necrotizing fasciitis for what it truly is, which is a time-sensitive surgical emergency that is disguised as a routine soft tissue infection. So when we build this framework that I call Save the Fascia, right? Is to help recognize rapid recognition and escalation protocol designed to force early action before irreversible soft tissue loss occurs. Because necrotizing fasciitis infection is one of the most dangerous misconceptions that is believing that time is on your side. Time is on nobody's side, especially when it comes to necrotizing fasciitis. So the question isn't what does it look like right now? It's more how much is it changing while I'm literally making a decision. And then also May 31st is actually necrotizing fasciitis awareness day. This is a day dedicated to education, early recognition, and highlighting how quickly this disease can turn from subtle symptoms to a life-threatening systemic collapse because the awareness isn't just about academics, it's about the awareness of limb salvage. It's some cases it's life-saving because the mortality rate is quite high for necrotizing fasciitis. And I think everybody's been seeing it in the news. There's multiple cases. There was even quite a few with the vibrophalunculus necrotizing fasciitis, and then, retained foreign body neck fash happening. So I hope this episode is going to help, even if it's at least one person, to rule out neck fash because people think necrotizing fasciitis is rare, but in wound care, it is not rare enough. Because I feel like a lot of wound care specialists do know how to recognize necrotizing fasciitis early enough because we see it quite often. I think I see neck fash often enough to know when it is neck fash. So, what is necrotizing fasciitis? I've done multiple episodes on it. I will continue to do episodes on it because honestly, people really think it's that rare, but it's not that rare, in my opinion, because too many people are lost from it because it's not recognized early enough. So, necrotizing fasciitis, what is it? It's a rapid progression of soft tissue infection that primarily attacks the fascia, the subcutaneous tissue, blood vessels, as well as eventually gets to the muscle and skin. And the fascia, why the fascia? Because the fascia is like a highway. The infection spreads under the skin before the skin surface actually reveals what's happening. And that's why early neck fash can look deceptively benign, like a tiny puncture wound, a diabetic blister. It looks sometimes like an insect bite. It can start off as a scratch or even a surgical incision, but underneath the tissue is dying. So why the fascia? What is the fascia? The fascia is a connective tissue network that wraps nerves, muscle, vessels, and even organs. And think of the fascia as like a shrink wrap around muscles or the underground subway tunnel beneath the city. So bacteria actually exploit these planes because fascia has a poor blood supply. The immune cells reach it much slower. Antibiotics penetrate fascia less effectively, and the planes allow rapid lateral spread. Bacteria isn't such simply just eating the flesh. When bacteria touching the fascia, it releases toxins. It causes microvascular thrombosis. It shuts down perfusion. It creates ischemia, and it causes liquefying tissue from within. So that's why I came up with Save the Fascia, okay? So what's more important when it comes to the real clinical practice? This is not a mutually exclusive disease, okay? A single patient can progress from cellulitis to neck fascia to gas production to toxic shock and to death, okay? And that's why early recognition is not just simply important, but it's actually quite life-saving. So, I'm gonna go a little bit about history of it. I'm sure I haven't before. I have before. So, in 1871, somebody called Joseph Jones published one of the first systematic medical descriptions of necrotizing fasciitis during the American Civil War. He analyzed 2,642 soldiers. They had nearly a 50% mortality rate. He described this as tissue literally dissolving, the skin melted away in quotation marks. And this is one of the first attempts to medically organize and classify this disease. He said that it was a rapid spread, overwhelming systemic toxicity, catastrophic mortality, and tissue necrosis. And what he was witnessing was literally like streptococcus, neck fasc. There's actually categories of necrotizing fasciitis, mixed anaerobic gangrene, severe systemic syndrome, and clostridial infection. So medicine solely recognized these diseases all shared the same core pathology, which was rapid soft tissue necrosis. So over time, it had older, different names like hospital gangrene, Melanie gangrene, Fagnesia, Phagocytosis, I know I'm pronouncing that wrong, so forgive me, or streptococcal gangrene. Then in 1952, which is quite recent, a gentleman named Ben J. Wilson coined the term necrotizing fasciitis, and thank you, Ben. So why this mattered is because it emphasized that there was fascial necrosis. It separated it from ordinary cellulitis, and it clarified it as a surgical urgency, okay? And Ben Wilson, key insight was the muscles may initially be spared while the fascia dies first. And this is still a concept today because, quite a few people have died from necrotizing fasciitis. Even one of the well-known people, it's like a type of neck fasc. It was Jim Henson, the Muppets, right? They say it might have been toxic shock syndrome, streptococcal toxic shock syndrome. But remember Jim Henson from the Muppets? He died from an overwhelming invasive group A streptococcal infection that progressed to streptococcal toxic shock syndrome, TSS, and many infectious disease experts considered this case as part of a broader spectrum of necrotizing soft tissue infection, even though it wasn't publicly diagnosed specifically as classic necrotizing fasciitis. But it happened in May 1990 when Jim Henson reported that like fatigue, sore throat, flu-like symptoms. It can have symptoms like the flu, cough, malaise, and the patient, Jim Henson, he initially thought it was a minor thing and kept working. And then over several days, the infection worsened dramatically. And by the time he finally went to the hospital, he had severe respiratory distress, was coughing up blood, multiple lung abscesses, and rapidly progressing into multi-organ failure. And doctors determined that the infection was caused by Streptococcus pyogenes, also known as group A streptococcus. Mnemonic is gas. Streptococcus A, group A streptococcus, okay? And this is the same organisms that is associated with strep throat, scarlet fever, streptococcal toxic shock syndrome, and in many cases, type 2 necrotizing fasciitis. So necrotizing fasciitis is not one single disease. It's ecosystem war, okay? So different bacteria evolve different methods of destruction. So there are different types of neck fasc. So there's type 1. Type 1 neck fasc is the polymicrobial one, the polymicrobial alliance one. Type 1 neck fasc is in 70 to 90% of cases. This is a team attack. So it usually found in diabetic vascular patients, immunocompromised patients, traumatic wounds, and post-operative wounds. And these infections involve multi-organisms working together, such as anaerobes, gram-negative, streptococci, enterococci, and bacteriodes. So how polymicrobial neck fasc works, one organism lowers the oxygen tension, another one destroys tissue, another one produces enzyme, another one creates gas, another one evades the immunity, and together they will create ischemia, thrombosis, tissue liquefaction, fascial plane destruction, and the fascia becomes a bacterial highway. Now, like I said, the fascia is this thin connective tissue plane that surrounds muscle, nerves, vessels, and compartments, and has a relatively poor blood supply. So underneath, it can travel very fast, okay, and it doesn't respect the skin boundaries. Now, type 2 neck fash is the streptococcal one. So type 2 is usually caused by group A streptococcus. This is often the one that presents in healthy person who dies suddenly scenario. So Streptococcus pyogenes, this bacterium has evolved a terrible virulent mechanism. So it uses exotoxins, it uses super antigens, as well as destroying the tissue enzymes. So, how does Streptococcus pyogenes destroy tissue? It produces streptolysins, hydrolyzase, DNase, and pyrogenic exotoxins. And these enzymes destroy tissue barriers, destroy the immune cells, spread through the fascial planes, and trigger cytokine storms. So the super antigens, these are the immune system nuclear bombs, right? So these are one of the scariest mechanisms. Normally, your immune system selectively activates, okay? But streptococcal super antigens activate this massive number of T cells simultaneously, which would result in this explosive cytokine release, shock, capillary leak, as well as organ failure. And this is why patients can deteriorate unbelievably fast. Then we have MRSA and modern neck bash. So MRSA, what does MRSA stand for? MRSA stands for methicillin-resistant Staphylococcus aureus, which has evolved this resistant mechanism that made treatment quite harder. So there's community-acquired MRSA that has added a toxin production, abscess formation, as well as severe skin destruction. So now clinicians have to fight the virulence as well as the antibiotic resistance. Now type 3. Type 3 is gas gangrene as well as marine bacteria. This is the one where you hear fibrofolunculus. Also, there's a fourth one, which is fungal, right? But type 3, like Clostridium species, these organisms produce alpha toxins as well as gas formation as well as massive muscle destruction. This is true myonecrosis, and the tissue literally becomes devitalized, gas filled, and ischemic. And then the crackling sensation is known as crepitus. This is because of the gas that accumulates in the tissue. The vibrofurunculus, which people have been warning people about, especially when it comes to summertime, the vibrofurunculus is often linked to seawater exposure, shellfish, as well as liver disease. So progression can rapidly happen, and patients often deteriorate within hours. And then type 4, which is the fungal neck bash, that one is quite rare, but still devastating, seen most in profound immunosuppression patients, transplant patients, or uncontrolled, okay, diabetic patients. And the fungus can invade the blood vessels directly, causing thrombosis, ischemia, and tissue death. So, I gave a little bit about it. So, how does the infection spread? So, imagine the bacteria entering either through a puncture wound, ulcer, a fissure, trauma, or even an injection site. So, step 1, the bacteria enters the soft tissue. Step 2, it releases these enzymes like streptokinase, DNase, as well as hydrolyzase, and these dissolve the connective tissue barriers. Step 3, there is something called microvascular thrombosis that occurs. These are tiny vessel blood clots, and now the oxygen can't reach the tissue that well. Then step 4, ischemia develops. Step 5, tissue dies. The dead tissue becomes a fuel for bacteria. Step 6 is the gas may form, and step 7, the fascial planes become these tunnels for the bacteria, and the infection outruns the immunity. So why is NetFast so time sensitive? The time course is quite rapid. So early phase 0 to 24 hours, the skin may look normal, but internally the fascia becomes inflamed, edema does spread, and the vessel thrombose. Symptoms are severe pain, swelling, tenderness, flu-like symptoms. This is where most diagnoses do get missed. Then the intermediate phase is 24 to 72 hours. Now the skin changes do appear: erythema, dusky discoloration, edema, the bullae, okay? So these are big blisters. So the pain also intensifies, so that's why you should never downplay anybody's pain. fever rises, tachycardia does develop, and systemic toxicity begins. The late phase is 72 hours plus after infection of this, okay? So this is when anesthesia develops, okay? They start getting numbness. Necrosis worsens because anesthesia because of the nerve vessels dying, right? The skin turns purple or black, the crepitus begins to appear, and septic shock develops, okay? So the nerve dies, but ironically, pain may suddenly decrease, right? But that doesn't mean improvement. That's because the nerve destruction has happened. So our protocol, the Save the Fascia protocol. So S, right? Save the fascia. S-A-V-E, T.H.E, fascia, F-A.S. S.C.I.A, save the fascia, okay? So S means for stop the contamination. So this is immediate stop exposure source, right? So examples are remove the contaminated dressing, clean the wound, stop ongoing trauma, remove any constrictive footwear, things like that, right? And if it's a diabetic ulcer, you have to offload. If it's a puncture, you have to remove any foreign body, right? A, aggressive irrigation. Irrigation alone is never enough, okay? So if there's any type of trauma wound, any wound, anybody who's in wound care knows to evaluate extensively. Check, probe, use a hemostatus. You have to probe, 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 probe. See if there's any fascial planes going anywhere, if there's any tunneling, and if there's any sinus, okay? But aggressive irrigation. So flush the wound thoroughly, right? What I would do if it was me, I would definitely get this hypochloric acid is supposed to be really good for this. Can kind of they say neutralize the toxin. If you don't have hypochloric acid, I would just use iodine and saline, wash, irrigate properly, and then probe. And if your X-rays come negative and you're not sure, you want to make sure, okay, get a CT. Okay, CTs are great, or a ultrasound. But I would get a CT. Aggressive irrigation. So flush this wound thoroughly because bacterial load does matter. Irrigation never is enough, okay? You have to explore the wound appropriately. But irrigation does decrease surface contamination, helps remove debris, and, again, like I said, the danger is irrigation alone cannot stop neck fasc once neck fasc has evaded the fascia. B, V stands for verified tetanus status. So not because tetanus causes neck fasc, but any traumatic wound, puncture wound, anything like that, you have to verify the patient's tetanus status because traumatic wounds require complete infection assessment. So, this step helps prevent us from having that tunnel vision. So E, evaluate the wound carefully. So this is a critical diagnostic step. We have to look for disproportionate pain, edema that is beyond the erythema, rapidly spreading cellulitis, skin discoloration, if there is any hemorrhagic bullae, if there's drainage throughout ulnar, and compare both extremities, right? So next, you have to compare both limbs, right? Most of the time, it's unilateral. So T, track progression. So neck fasc changes fast, okay? So we have to track the progression. So mark the borders with a skin marker. Recheck every hour, every few hours. Rapid expansion is a massive warning. So cellulitis usually progresses slowly, but neck fasc can spread centimeters per hour. H, hunt the systemic toxicity. So we have to look for tachycardia. We have to look for hypotension. We have to look for altered mental status like confusion. We have to look for fever. We have to look for elevated lactate. We have to look for metabolic acidosis. So neck fasc is not just a skin infection. It becomes a whole body catastrophe. E, escalate immediately. So do not wait for skin necrosis to show. Do not wait for imaging confirmation sometimes, because if you have a high suspicion, rule it out, okay? If there's gas or black tissue, surgical consultation should always happen early, okay? So this means most likely if you see these signs, right, the patient most likely will need surgical debridement, broad spectrum IV antibiotic, possibly ICU support. Delay is the thing that kills these patients. Now, the last part of the protocol, fascia. So fascia, fast progression. If rapid change of the skin is one of the biggest hallmarks, right? Of neck fasc. Cellulitis, like I said, evolves slower. Neck fasc can dramatically worsen within hours. Within hours. So time is not on our side with neck fascia. A, anesthesia of the skin. This is a late finding because the nerves become infarct, the tissue dies, and sensation disappears. This is ominous. So this is not a good sign at all. S, swelling, severe swelling. Edema exceeds visible redness. Why? Because the inflammation tracks deeply through the fascial plane. Fluid accumulates below the surface. The bulla, like these big blisters, right, are more characteristic of skin and dermal ischemia or inflammatory fluid linkage. C, crepitus/cellulitis. Crepitus occurs from the gas production. Gas-forming organisms like anaerobe, Clostridium, mixed infection, okay? But absence of crepitus does not rule out neck fascia. I, intense pain. So intense pain is one of the classic findings, pain out of proportion during a physical examination. Why? Because the fascia contains the sensory nerves and the deep inflammatory destruction hurts before the skin necrosis happens. So this is one of the biggest clues. And our last letter A. A is for altered skin color. So skin evolves. Red, dusky, biologists, oh, I know I'm not saying that right, gray, black, and this can reflect ischemia, the thrombosis, and the necrosis. So, our mandatory golden hour rule. So, if neck fascia is suspected, within 60 minutes, the patient should be within broad spectrum IV antibiotics. You need to obtain labs, CBC, CRP, lactase, CMP, blood cultures, and imaging only if the imaging does not delay the surgery, okay? Within 90 minutes, surgical consultation must be activated and, possible transfer to OR, ask the patient MPO, when's the last time you eat, okay? But the key rule is do not wait for imaging confirmation if the clinical suspicion is high. So what is the standard antibiotic bundle for this, okay? Coverage must include MRSA, gram-negative rods, anaerobes, streptococci, and the combinations are usually institution dependent, but like vancomycin, zosyn, vancomycin, cefepime, metronidazole, or an adjunctive, clindamycin. Clindamycin, why? Because toxin suppresses the streptococcal infections. Now, surgical escalation criteria. Call surgery immediately if any of the following: rapid spreading cellulitis that is greater than 1 centimeter per hour, severe pain with minimal findings, bulla or skin necrosis, crepitus, elevated lactate, okay? And then if there is any patient that's hemodynamically unstable. And so our diagnostic pathway, you don't use it to delay, okay? So CT, CT does help the gas tracking. CT does help watch our fascial plane technique. MRI has the best sensitivity for fascial plane involvement. Ultrasound is fast, uh, for bedside for gas detection, okay? But imaging must never delay surgery if the suspicion is high, okay? We're going to talk about the learning more. So also wound handling, okay? No primary closure for contaminated wounds or unclear wounds. Mandatory irrigation and debridement. Mandatory irrigation and debridement for dirty wounds, okay? Foreign body removal is non-negotiable when it comes to this, and then reassessment of wounds every 24 to 48 hours if infection risk exists. So when it comes to clinical reassessment, all infected wounds must be reassessed every 6 to 12 hours in inpatient settings and every 24 to 48 hours in outpatient, okay? You have to look for expansion of erythema, increase in pain, skin changes, and systemic decline. Now, when it comes to documentation, right, you have to describe the patient's pain. You have to ask the patient their pain, okay? You have to do skin marking mapping. You're supposed to mark the cellulitis or erythema, okay? See if it's going proximally or going distally, okay? Vital sign trends, sepsis screening, escalation decision rationale. Like, why do you suspect that it's possibly neck fascia? Why do you suspect that it's not neck fascia, okay? And then education matters. Patients must be taught not to ignore rapidly worsening signs. They should be taught not to wait it out, especially if there's redness and swelling. You should seek immediate care if there's rapid swelling, fever with a wound, or skin changes happening. So, what are our differential diagnoses when it comes to this? Cellulitis is one of the biggest differential diagnoses, right? Usually, cellulitis is superficial, slower in progression, less toxic in appearance, and less severe pain. Okay, gas gangrene. and I will go through an episode about the difference between gas gangrene, neck fash, and another thing, okay? So usually with gas gangrene, these are usually caused by Clostridium species, more associated with trauma, crush injuries, devitalized tissue. We see gas a lot of times with diabetics, okay? But this produces dramatic gas formation. Muscle involvement is more prominent gas, okay? Polymyositis. Myositis. Okay. Well, inflammation of the muscle. Okay. This is primary muscle infection. MRI helps distinguish it. Next is venous dermatitis. Okay. This can mimic cellulitis, but is usually chronic, bilateral, and less systemic toxicity. Okay. Deep vein thrombosis, usually unilateral. Most of the time, I rarely see a bilateral DVT, but it is feasible. Swelling and pain may mimic infection, but ultrasound do help rule out DVTs. Now, our lab tests, okay? Lab tests do come in handy, elevated white blood cell count, okay? But hold on. The other thing is sometimes neck fash starts with a normal white blood cell count. So having a normal white blood cell count does not exclude neck fash. Lactate. Remember, high lactate suggests hypoperfusion, severe sepsis, and tissue ischemia. So that's very concerning. CRP, often markedly elevated in neck fash. Sodium. Sodium is usually low. Hyponatremia is common. Why is that? Because there is a massive inflammatory fluid shift. So let's do the Lernick score. What is the Lernick score? LRINEC, Lernick score. What does that stand for? Laboratory Risk Indicator for Necrotizing Fasciitis. So the Lernick score use routine laboratory values to help identify patients who are at high risk of necrotizing soft tissue infection. This is critical. I said critical. This is critical, but Lernick score is not just a tool to rule out, okay? If the score is low, it does not guarantee that the person does not have neck fash, okay? But if your clinical suspicion is high, you know, evaluation, escalation care, and imaging still would help, okay? So neck fash is diagnosed clinically first, okay? Lernick score is just adjunct, okay? So why does Lernick score exist? Because necrotizing fasciitis causes overwhelming inflammation, tissue ischemia, immune activation, metabolic stress, sepsis, and microvascular collapse. So what are the components of the Lernick score? And why it matters. It uses 6 laboratory markers: CRP, which measures inflammation; your white blood cell counts, which help measure your immune activation; your hemoglobin, which reflects your hemolysis or hemodilution; your sodium, which reflects your systemic inflammatory shifts; your creatinine, which reflects your kidney injury; and your glucose, which reflects your metabolic stress. So their scoring table, people should look up the Lernick scoring table. So CRP, the CRP is equal to or greater than 150, that gets 4 points. If your white blood cell count is 15 to 25, that gets 1 point. If it's greater than 25, you get 2 points. If the hemoglobin is 11 to 13, that's 1 point. If the hemoglobin is less than 11, that gets 2 points. If the sodium is less than 135, that gets 2 points. If the creatinine is greater than 1.6, that gets 2 points. If your glucose is greater than 180, that's 1 point. So what is the interpretation of that? So if the score is less than 6, that means the patient is at low risk. But like I said, it does not exclude neck fash, okay? Don't just be like, oh, the Lernick score is this, and they don't definitely have neck fash. Because one problem with neck fash, it's more misdiagnosed than overdiagnosed. That's the problem. So if it's 6 to 7, that means the patient's at immediate risk. And if it's greater than 8, that means the patient is more at high risk, okay? But like we said, the early disease of neck fash can deceptively have normal labs. So why does CRP matter? CRP is the acute inflammatory protein that's produced by your liver, okay? The body senses infection, the body senses tissue destruction, the cytokine release. The liver floods the blood system or the bloodstream with CRP. Neck fash creates massive inflammation, widespread cytokine signaling, and rapid tissue necrosis. And that's why CRP becomes extremely elevated, okay? And so why is the cutoff so high, the 150? If it's greater than 150, that's 4 points, right? Because that's a huge inflammatory burden. 150 CRP is crazy high. This is not mild cellulitis territory. This means that there is severe soft tissue destruction, profound inflammatory activation, and systemic infection. And why is that? Because the bacteria are releasing toxins. Your immune cells are trying to release cytokines. The IL-6 stimulates the liver, and the liver produces CRP. So the more aggressive the inflammation, the higher the CRP. So also CRP is also elevated in osteomyelitis, severe cellulitis, autoimmune disease, trauma, surgery, as well as abscess. Okay, so CRP supports suspicion but does not diagnose NAC fascia alone. Now, your white blood cell count. Why is the white blood cell count rises? Because the immune system detects this bacterial invasion and responds by releasing the neutrophils, having your bone marrow stimulated, inflammatory recruitment. The body is trying to mobilize itself for war. So, if your white blood cell count is greater than 25, that is quite extremely concerning. That means that there is a severe infection going on, systemic inflammatory response, and possible sepsis. This happens in NECFAST. Why? Because there is, again, a toxin release, widespread inflammation, there is a bacteremia risk, and there's tissue necrosis going on. So your immune system is pretty much going in overdrive. And the important caveat is that some patients with severe NECFAST may actually have normal white blood cell count or low white blood cell count. Why is that? Because the the sepsis can actually become so overwhelming that it can exhaust the immune system, and that is especially dangerous. Now, our hemoglobin. Like I said, if the hemoglobin is 11 to 13.5, it's 1 point. If it's less than 11, that means it gets 2 points on the learning score. Why would NAFFAST lower hemoglobin? Several reasons. One is the capillary leak. So inflammation damages the vessels, the fluid escapes the tissue, the blood becomes diluted, and this lowers the hemoglobin concentration. B, hemolysis. The bacterial toxins can damage the red blood cells, and that can contribute to anemia. Bleeding into the tissue. So necrosis and vascular destruction can cause what we call tissue hemorrhage and bleeding into the fascial spaces. Next is chronic diseases. Many patients with diabetes already have chronic anemia, kidney disease, inflammatory disease, and neck fast can worsen this. Now, our sodium, because I'm just going in so people could understand. So our sodium, if it's less than 135, like I said, that gains you 2 points on the learning score. Hyponatremia, hypo is low. Hyponatremia is NAFFASH. In NAFFASH is a big red flag. Why is that? Because sodium drops because there is a massive inflammation. That means there is vascular permeability going on. That means that the fluid is shifting into the tissues. And that means that the body is becoming it's becoming filled with a lot of edema. And the water leaves the blood vessels and accumulates in the soft tissues. And this is what causes the dilution of the serum sodium. Now, the cytokine storm that's going on because of that, the inflammation also increases something that is called ADH, the antidiuretic hormone release. So that causes water retention. So there is more dilution, and that causes a lower sodium as well. So clinically, that means the hyponatremia, low sodium, shows or reflects severe systemic illness, aggressive infection, as well as profound inflammatory response. So low sodium is simply not just simple cellulitis. Clinicians should become nervous when you see a patient having low sodium and an infection is brewing. Creatine, okay? If it's greater than 1.6, that gains you 2 points on the learning score. Creatine, I know I'm pronouncing wrong, forgive me. Creatine, that is measured by your kidney function. NECFAST can rapidly damage your kidneys through sepsis, through hypotension, through dehydration, through shock, and rhabdomyolysis. How does that happen? Because the infection, as it spreads, the blood pressure drops, your perfusion worsens, the kidneys receive less oxygen, and acute kidney injury develops. So there's a connection with septic shock. So in severe neck fast, there's a cytokine brewing or happening, vasodilation, there's a capillary leak, and then the microthrombi. These all impair your kidney perfusion, your renal perfusion, and the kidneys begin to fail. Now, with your glucose being super high, right? Let's say if it's greater than 180, that gets you 1 point on the learning score. High blood sugar is extremely common in neck fast, especially in diabetics. Why is that? Because severe infection triggers your cortisol release. Severe infections trigger catecholamines. severe infection triggers glucagon because it needs more energy. And then it also triggers your stress hormones. That's why this increase in blood sugar is called stress hyperglycemia. So why does diabetes can make this worse in patients? Because it impairs the neutrophils, it weakens your immune system more, promotes bacterial growth. Bacteria loves sugar. Everybody needs sugar. It loves sugar. That's one thing about bacteria. And it worsens your circulation. So this creates the ideal environment for neck fast progression. But like I said, the learning score is quite helpful when you suspect severe soft tissue infection, if the diagnosis is unclear, if you need additional risk stratification, okay? But you should not rely on it as just a screening tool. You shouldn't rely on it to rule out neck bash. You shouldn't use it to just delay surgery, and you shouldn't use it to override clinical suspicion, okay? Like I said, neck bash seems to be more underdiagnosed than overdiagnosed. So the most important thing is, the learning score should support your eyes, but not replace them, okay? Because necrotizing fasciitis ultimately is needs surgical intervention. It's time-sensitive emergency and needs clinical diagnosis, okay? So the patient pain, the speed of progression, the systemic toxicity, and the fascial destruction matters more than that score, okay? And that's why that's why I came up with that Save the Fascia protocol, okay? Because it should never override clinical suspicion. Now, surgical exploration. This is when you have neck FAST, this is a definitive diagnosis that often you're gonna make your way to the OR. Classic findings, they always say gray dishwater fluid, lack of bleeding, necrotic fascia, easy blunt dissection, foul odor, because healthy fascia resists dissection. Necrotic fascia falls apart very quite easily. So, antibiotic, we already said that it's supposed to cover, but clindamycin is very important as well because it suppresses the toxin, especially in the streptococcal disease, okay? So what's one of the biggest mistakes, like I said, with people with neck rash? They underdiagnose. They're waiting for imaging. They're waiting to see if there's gas. They have uncertainty. They feel like they might be overreacting. No, it's better to overreact than underreact, in my opinion, because if it's because you misdiagnosed it and that person lose more tissue or even possibly their life, that's something you can't take back, okay? So the earlier, the better. The earlier the debridement, the earlier the removal of the infected tissue, the earlier the patient gets on IV antibiotics, the earlier the surgical consultation is everything, okay? So necrotizing fasciitis teaches us one brutal lesson that the skin can lie, okay? But by the time it gets to the surface, it can be so catastrophic that the deeper tissues are already dying. So always remember that acronym of SAVE the fascia, S, stop the contamination, A, aggressive irrigation, B, verify tetanus status, E, evaluate wound carefully, okay, fully, okay, T, track the progression, H, hunt systemic toxicity, E, escalate immediately, F for fascia, fast progression, anesthesia of skin, S for severe swelling, C for crepitus, I for intense pain, and A for altered skin color. This is not just a mnemonic, this is a mindset, so we can help recognize neck fast earlier, track the progression, respect if the patient has pain, okay? Never downplay a patient's pain. That's one of the also biggest problems, okay? Everybody's so subjective because you can't feel pain, can't feel the patient pain for them. Just respect what the patient is saying, monitor if they're feeling the pain, okay? But you have to escalate immediately if you ever suspect neck fast, okay? Because neck fast is more about hours than days. Because sometimes the difference between life and death is whether somebody recognizes that the fascia is already infected and that this is a severe life-threatening disease that's going on underneath the skin, okay? And this is Diabetic Foot Files. I hope everybody liked this. And don't forget, May 31st is Necrotizing Fasciitis Awareness Month. And this is Diabetic Foot Files. Take care of your feet because they take care of you.